we'll come back to the satellite symposium. So the next presentation will be Cvetomil Petrov speaking on life-threatening genital bleeding and pelvic congestion syndrome.
So, hello everyone. I'm not Dr. Cvetomil Petrov, I'm Dr. Damian Bojchev, but he's absent, so I will do the presentation instead of him. And we are going to present life-threatening bleeding and a pelvic congestion syndrome, a single case report and a little overview of the condition. So we had a 35 years old lady presented to our clinic, sent from her OB obstetric and gynecology doctor, sent after period of miscarriage and period of profuse bleeding with the need of a few hemotransfusions. At the day of the admission at our department, he was with hemoglobin levels of around 100, and she had also a previous healthy child with normal birth. So she had for the past year severe complaints of pelvic pain, pelvic discomfort, abdominal pain. She had some edema of the external genitalia, and she had dyspareuria, which is a complicated word for discomfort and pain during and after sexual intercourse. So I already present you this. She had a life-threatening bleeding during miscarriage a few months back, and afterwards she had a few exams from her OB and also a few other gynecologists. And she had continuous bleeding outside of her regular period. Also, she did an MRI of the pelvis, and the conclusion of the radiologist was that she may have some ovule malformation, and she was sent for continuous and diagnostics. From the different gynecologists, she was sent finally to the cardiology department. So from the physical examination, she had nothing very interesting besides the persistent genital bleeding and the palpable pain in the pelvis. So from the blood test during admission, hemoglobin 91 and nothing else, exactly like we expect from a young woman, of course, some iron deficiency anemia. I'm sorry for the pictures, I didn't have some time to edit them. This is just on the video, the MRI scan, and here are the exams. Here on the, can you see the pointer, maybe? No. Yeah, okay. Here on the right side, near the right femur, you can see the venous congestion in the anomalous venous cluster of vessels, which was initially recognized as an EV malformation. We later on discussed it with our radiology department and also did a CT angio with venous phase. Here is a bit slow on the video, and later on I will show you the still pictures, which are maybe the most informative of all. Okay, let's go. Oh, I'm sorry. Let's go back. Just wait. In the end, we can see the congestion in the pelvis. And after doing the CT scan, we decided to do an invasive intervention, invasive diagnostics at first. She was maybe something we should say that she was very, very, very anxious as a patient. She was anxious because of having a little child at home, and also in the past year he was practically invalidized disabled by her pain in the pelvis, and she was almost not going out and almost always laying in the bed or maximally sitting. Here we have the left iliac angiogram. Here on the center of the image we can see some type of malformation which is being supplied by the by the left iliac artery. We discussed that with the treating gynecologist, and she had this described on the echoes and the MRI, and it was interpreted as probably angioleomyoma or angiolipoleomyoma, some rare types of myoma, but as we all know, without biopsy, we can't be sure of the exact morphology of the tissue. Here yet again another projection. Here are the left and right iliac veins. No particular pathology from here. And here is the left renal vein. I'm sorry for the pictures yet again. And here the left ovarian vein. Here on the right is most clearly seen that the cluster in the pelvic area. This is the venous congestion that is probably causing her pain. And as we saw that, we thought that what's next, what we should do. And on the table were to terminate the procedure and to think more and to discuss it on the multidisciplinary discussion, what is the best for her with her gynecologist, to appoint different diagnostics, or to schedule embolization procedure in the future, or of the left ovarian vein or the left uterine artery. But as I said, she was extremely anxious during the procedure, and she said, you do what you do what you have to do, I'm not coming back. I don't want to stay in the hospital, I want home, I will not won't come back. So what we should do, we discussed in a lengthy discussion, we decided to do embolization of the left ovarian vein. So what we had available in the cath lab, we had a sclerotic agent, we had Surgispon, PVA, or and 3. I am emphasizing on the fact that we have just 3 available coins of the appropriate size. And we decided to do embolization with the available coins using right femoral vein, with mammaria catheter and Cobra microcatheter. We selectively cannulated the left ovarian vein. We went as distal as possible, and we implanted 3 coins in the left ovarian vein. Here is the 3rd coin, and this is the final result. The final result is not the perfect one. We thought about also using sclerotic agent finally, but on the right picture you can see that there are some paravertebral veins which are showing, and we decided that there is a risk of embolization with using it, and also we didn't have more available coils. So we decided to stop the procedure at this this moment, to see how the patient is and to think about her maybe coming back if she decides to come back. But during the follow-up, actually the result was great, and after the first week she didn't have complaints from the puncture side, and also the 3rd week she had a significant reduction of the abdominal pain and pelvic pain. Also she had a reduction in the edema of the external genitalia, so it was great. And during follow-up, actually on the 12th week, she was pregnant again, which was actually a great result after all. So we are just following up because the procedure was the last fall, so she's still pregnant. So yeah, we will follow up how the things go. And here some more information about regarding the efficiency of embolizations of pelvic congestion. Actually, a quarter of women have pelvic discomfort or pelvic pain, chronic pelvic pain, which is a huge number. And the studies show that 30 to 40% of this pain actually is caused by some form of congestion syndrome. And in a lot of those cases, we have similar angiograph features as the one we showed you. And this systematic review actually includes 25 studies in over 2,000 patients with average age of 37 years. And the studies were in the period of 97 to 2022, so a very big period with very big improvements in medicine and in the field. Here from the study we have, from the article, we have a table which sees and evaluates the efficiency of the procedure, and actually you can see that the efficiency is absolutely great. And here in the field, in the second column actually, in the field of improvement, there are way bigger numbers than the one in the no improvement group, and even in the second table, I'm sorry, I didn't thought that it's not going to be seen clearly. Here on the table we have comparison of p-values and calculations about the improvement of symptoms pre and post procedure. In almost all studies and almost all patients we have improvement in the clinical symptoms, which after all is a great result. The classical treatment, or conservative one of this disease, actually is hormonal treatment by the gynecologist, but at least in Bulgaria they're not doing it pretty often. I don't know why, it's out of our specialty. To be honest, and other things, it's in big number of patients which have this problem before giving birth. After pregnancy, the problems go away. Thank you.
I guess I don't have any questions. Do you have any questions? No? Okay, thank you very much.
Thank you.